everyone for joining us. My name is Brianna. I'm one of the genetic counselors at Swedish Cancer Institute. I work within the Hereditary Cancer Clinic with a multidisciplinary team of surgeons, oncologists, radiologists. I have my colleague here with me today.
Hi, my name is Sherry May. I'm also one of the genetic counselors at the clinic.
Well, thank you both for joining us today. I'm really interested about this topic myself. So how about we start with what is genetic counseling?
Sure. So genetic counseling is a specialty where we talk with families about different genetic syndromes. So there's actually a variety of different types of genetic counseling, whether we're talking about pediatric, prenatal, or like Sherry May and I practice is cancer. So we have special training in medical genetics, and we try and help families understand how a genetic result might impact them or their families.
Great. And who would benefit most from genetic counseling, and what can patients expect through an experience with genetic counseling?
Yeah, sure. So a lot of our patients either have a cancer diagnosis themselves or they have a family history of cancer. And typically in a genetic counseling session, we start off with a family pedigree, 3 generations. So we ask about grandparents, aunts, uncles, siblings, children, and even grandchildren, sometimes even farther than that. And then we'll talk about what we know in cancer genetics and kind of discuss what syndromes we may be considering based off of what we see in the family history, and also what those genetic or what their genetic testing options are.
Great. And when you say genetic testing options, what types of genetic tests are there?
Sure. So most often we're ordering testing that looks at different genes that are inherited from one parent or the other, that if there is an inborn mutation in that gene, that the risk for certain cancers could be higher. So most of the time we do genetic testing through a blood sample or a saliva sample, and we look at that long strip of code to see if we can find any inherent mutations. So yeah, saliva or blood.
And every once in a while people ask about what's the difference between our type of testing and something called somatic testing, which is looking at mutations that are found in the tumor. Mutations in a tumor can change over time, either from external factors like maybe radiation exposure or other things in the environment. And that is helpful in cancer treatment, but that doesn't tell us about their specific cancer risks for developing another type of cancer and risks to family members. And so we can compare and contrast both and see how it's helpful. But in our case, we do germline testing and look for changes that are inherited that you can pass on.
Right. Yeah, the tumor can look very different than the set you were born with.
Okay, great. So I've heard a lot about BART and Brca genes. Can you speak to those? And are there any other like red flag genetics or codes that people should be aware of?
Yeah, so Brca is actually a name of a test that was patented by the lab who first started BRCA testing. So the actual gene is called BRCA1 and BRCA2. And what BART is the second piece of the genetic testing for BRCA. When we first started testing BRCA in the late 90s, we did testing called sequencing, where we looked at letter by letter in the DNA code. We know how to spell it, and so we just look for changes. And it wasn't until mid-2000s, 2006 or so, that they developed another type of test that would help us look for large rearrangement. So BART is also a name of a test called BRCA large rearrangement testing, because we found out that you can actually have huge chunks of BRCA1 or BRCA2 that are extra, that are missing, or they can be jumbled up. So if you think about chapters in a book, everything is spelled correctly, but the chapters are either missing or extra or in the wrong places.
And I'm imagining a lot of our audience is somewhat familiar with the BRCA genes, BRCA1 and 2. But for those who aren't, mutations in these genes go along with something called hereditary breast and ovarian cancer syndrome. Because women who are born with these gene mutations have very high lifetime risk for both breast cancer as well as ovarian cancer. Therefore, we're going to manage them very different than the average risk woman, namely maybe some kind of higher risk surveillance, or even risk reducing surgery.
Yep, and it's not that uncommon. We find that in the general population, the risk of carrying a BRCA mutation is about 1 in 400.
Wow. Okay. Thanks for the information. So we actually got a question from someone that's tuned in on our Facebook Live. When meeting with a genetic counselor, is there anything in particular I need to bring with me?
That's a great question.
Yeah. Do your homework. Asking family members about their health history can be really helpful, because we will be asking you a bunch of questions about ages at which people are diagnosed, what their course of treatment might have looked like, whether they had genetic testing, and in particular, if a family member has had genetic testing, if they have a copy of their report, that is imperative to bring to a genetic counseling visit, because that tells us exactly what we're looking for, what those risks are, and even what lab we need to send to.
And Brianna brings up a great point about bringing a family member's test report. And the reason for that is if someone who's had cancer and they've had genetic testing and is negative, even though that test result is negative for a hereditary cancer syndrome, other family members may still have a higher risk of developing certain cancers just based on family history. Because what we know for cancer risk is that family history is the biggest risk factor.
Great. So you've mentioned hereditary cancer syndromes. What exactly does that mean?
Sure. So these make up probably 10% of all cancers, really broadly speaking. Most cancers are not due to something you're born with. Again, as Sherry May had mentioned, it's usually probably something environmental or just the natural aging process that can cause a cancer. But for the hereditary types, individuals are actually born with an exaggerated risk already because of some kind of gene mutation that is inherited in this kind of 50-50 way in a family. So those individuals have higher risk for cancer overall. It's not a guarantee they would get a cancer, but the risks are much higher. They could be at a higher risk for rare types of cancers, and certainly at maybe even a younger age at diagnosis. Those are all hallmarks of a cancer syndrome in a family.
Yeah, and also, we've been talking more about breast and ovarian cancer, but we also know that there are tons of hereditary colon cancer syndromes, ovarian and uterine. There's another genetic syndrome called Lynch syndrome that's even more common than BRCA, where about 1 in 300 people have a mutation in one of the Lynch syndrome genes. And it can cause very early onset colon cancer, sometimes as early as the late 20s, early 30s. And on top of that, we tend to see a lot of other GI cancers in those families as well. So that could be pancreatic cancer, it could be kidney cancer, female cancer, ovarian and uterine cancer as well.
That's why learning about these early in a family can be so powerful.
Great. So how do you feel about home kits like 23andMe and Ancestry.com? It seems like they've really risen in popularity. Do you think that those are a good way of people kind of identifying if there are risks or not?
I think that's a little twofold. One, I am excited that people are excited about genetics, and I never want to stomp on that. So I'm happy that people are invested in learning more about their genetics. They're at-home tests, and a lot of what they're looking for is not necessarily directly connected to these kinds of syndromes. As of recently, 23andMe did get FDA approval to do a very limited form of BRCA testing when they're only looking at 3 different mutation types that are common in people of Jewish ancestry, but they are missing thousands of other kinds of BRCA mutations. So yes, it can look at some other maybe health reports or ancestry or this limited form of hereditary cancer testing, but it's certainly not a replacement for a clinical test.
Yep, and to add on to that, even for people who do come back positive for one of those 3 common Ashkenazi Jewish founder mutations in BRCA1 or 2, it can't replace a clinical test. And so clinical confirmation of those positive variants found on 23andMe is important as well. And it does say that on the report, which is nice because people can realize, okay, I may have one of these, but it definitely has to go through a clinical confirmation.
Very true.
Great. So we did get another question, and I know you touched on this with a couple of other responses that you had, but who benefits from genetic counseling?
Sure. I would say if there is a strong family history of cancer, especially a pattern of certain cancer types, like if there's many multi-generation of breast and ovarian cancer or colon and uterine cancer, particularly if it's at younger ages, those are all red flags for some kind of inherited cause. Or other kinds of young age cancers, although that's not true across the board. Some other young age cancers, like cervical cancer, are very unlikely to be hereditary.
And we always try and remind folks that it's best to test the family member who's been affected with cancer. And the youngest person in the family to be affected is way better than someone who's young, healthy, completely unaffected with cancer, because let's say we test that individual who's healthy and their test results come back negative. That's great news for that patient, but it doesn't give us information about the rest of the family, and it also doesn't tell us more about that negative person's risk for cancer. So if you test someone who's been affected with cancer, there's a higher chance of us finding a genetic mutation versus someone who's healthier. And then if that affected person's test results are negative, there are some computer models that we can use to help determine what those cancer risks are based on family history, some other personal factors, and also negative genetic test results.
And I'll just, on top of that, yep, a negative is not necessarily negative in that sense, right? We have 20,000 genes, and when we do genetic testing, we might be looking at 2 or 20 or 30, but it's still out of the 20,000. So there's a lot of families where there's lots of cancers, and we can't find the genetic underpinning. And so for those families, a genetic test is maybe not as helpful for other unaffected family members, but those unaffected family members still need to step up their screening because of that family history.
Great. So we actually have a question too regarding family. So what resources are available to families with hereditary cancer syndromes?
So that's a great question, and that's something that we definitely discuss when we find a positive genetic mutation. There's some great resources out there. One that's been around for the longest time is called FORCE, and FORCE is Facing Our Risk of Cancer Empowered, and they have resources for families who have hereditary cancer syndromes, what to expect for surgeries, kind of what it's like talking to your children about having this mutation, and even fun things like cooking classes. What are some foods that you might want to eat more based off of that hereditary syndrome that's running in the family? It's like, yes, you do have a very high risk, but what are some of the things that we can do to reduce that?
Bright Pink is another great one, geared more for young women who might have recently found out that they're BRCA positive. Similarly, it's got resources for advocacy groups, also peer-to-peer navigation, so meeting up with someone who is also maybe similar circumstance, just found out they have or had gone through the process of finding out they have a hereditary predisposition towards cancer. And having a buddy to navigate you through can be very helpful too. And for Lynch syndrome, it's Hereditary Cancer Takes Guts.
Yep.
It's another great one.
And thankfully, they have recently received support to continue in their endeavors, because we were actually a little bit worried for some time that they were going to have to shut down their services. But thankfully, they are still around. And, it's also important sometimes just to get extra emotional help, talking to a counselor or a therapist, because having a gene mutation can be extremely powerful and sometimes mentally and emotionally draining, because not only does it affect the person who's positive, but also their family members.
Great. Well, it sounds like there's a lot of resources out there. Thank you for sharing that with us. So what is the difference between a cancer that comes through aging, like you were talking about before, and an inherited cancer?
Sure. So the one that happens through aging or just sporadically, we call sporadic cancer, that one, it's not something that you're born with a high risk for it, but it might be some kind of external carcinogenic effect on a population of cells in the body. So whether we're talking about a population of colon cells, breast cells, pancreatic cells, what have you, there's usually some kind of damage that is happening to the genetic code itself over time. There's a lot of mechanisms in the body to go around and repair this kind of genetic damage as it happens. So it does take quite a bit of damage for a population of cells to essentially forget how to act like a normal cell and start going out of control. So all cancers are essentially genetic inherently. It's a culmination of genetic damage, but it's not like you were born with that genetic damage. It happened over time. Whereas the hereditary type, you have a small piece of genetic damage in a gene that normally protects you, that normally goes around and fixes that damage. So if you're born without that safeguard, your risk for cancer are higher. But not a guarantee you would get cancer. They can look different. There are some certain cancer types that are more suggestive of a hereditary. I won't go into that kind of terminology today, but yeah, there are some types that do tend to look more like a hereditary subtype.
Great.
Yeah, and just to kind of add to that a little bit, you know, with these genes, kind of one of the misconceptions is, oh, do I have this gene? And with the genes that we test for, we all have them. We have two copies, one from mom and one from dad. What we're looking for are changes, damages to that gene that's basically stopping it from working how it should be. And because of that damage, and it's because it's present in every single cell of your body from birth, once you get the second hit of that same gene, then the cell can lose its ability to control its growth. And so cancer is just basically this abnormal growth that the cells just keep replicating and dividing when they shouldn't be.
Okay, great. Thank you. So what's the next step once you've been tested for a genetic mutation and you test positive? What would be the next step in terms of working with doctors and things like that?
So typically we have some folks like to come back in and speak with us again about their positive test results. And most of the genes that we test for will have national guidelines. So it'll tell us what type of screening needs to be done, how often we should start screening, how old should you be when you first start screening. Because of these hereditary cancer syndromes, we don't want you to wait until general population to start their screening, but at a much, much younger age. And then we'll also talk about family members who are at risk. And then from there, we'll refer out to specialists either in our high-risk clinic or possibly even a surgeon to discuss preventative surgery. And nowadays, depending on what gene it is, surgery is very much just a personal choice. A lot of studies are showing, you can choose high-risk screening versus surgery and still live to be the same age. But I know a lot of patients their decisions are kind of based on family history, what they've seen, and maybe their mom or their sister that helps them drive to make a certain decision.
Right. And just as Sherry May said, that after they meet maybe with a genetic counselor again, we might, refer them back to their primary care if they're comfortable guiding them through screening, but there are some high-risk programs. I know, Sherry May, you just mentioned that Swedish does have a high-risk breast and ovarian cancer program run by a few of our nurse practitioners with expertise in these kinds of high-risk populations. So, and soon Swedish will also have a high-risk gastroenterology clinic too, run by a nurse practitioner for folks who have, say, Lynch syndrome.
Okay. And are there physical symptoms that one might experience when they have some kind of genetic mutation like this?
It depends,
Yeah.
right? For instance, there are some genes out there that may actually have more symptoms in childhood. I'm thinking of one specifically called neurofibromatosis type 1, or NF for short. And in those individuals, they're usually diagnosed with NF in childhood years because they can have skin pigmentation changes. Maybe they have some lumps or bumps present anywhere in the body, and maybe some eye changes as well that's present at a very young age. And as those women get older, we're seeing that they have a much higher risk of developing breast cancer in a very specific amount of time. So it just really depends on which specific mutation there is. Other ones can also have very specific facial characteristics where you have freckling and around the face and not necessarily anywhere else on the body, or they may have larger than expected head sizes in the 99th percentile, so they're being followed by that.
And a lot of these syndromes are quite rare, but yes,
True.
they can definitely go
Absolutely.
along with some of these. For the Brca genes for Lynch, there's no physical features at all. It's really more of an inherited cancer risk that some people can go their whole lives without ever knowing they have it.
Every once in a while, I know for Lynch, people may have that one skin change called a sebaceous neoplasm, which is a benign tumor that grows in your oil glands. And so most people, if anything, they get it removed because it's more of a nuisance, or maybe it's in a spot where maybe it's near their glasses, so they're constantly being irritated, but it's not necessarily a big sign because it can just be like a little tiny bump. So I don't really know if that would be even considered as a symptom that you can see right away.
Okay, thank you. So we have a question from someone that's tuned in our audience. What is the right age to consider testing children? My daughter's paternal grandmother had breast cancer, so I'm worried about genetic predisposition.
Great question. So generally we don't test children for hereditary cancer syndromes unless they go along with a childhood cancer. And in the case of a lot of these breast cancer-related syndromes, they don't. So usually the earliest I'd start offering testing is 18. Even 18 feels a little young. Guidelines for Brca mutation carriers, BRCA1 and BRCA2 mutation carriers, really the imaging kicks in about 25 years old. Yes, we do counsel women to be aware of their breasts, maybe do clinical exams with their physicians, but you really don't start imaging until 25 anyways. So 18, sure, they have the ability to test if they want. Sometimes we wait till 25. 18 is usually a time of transition too. Other than that, if there's no gene mutation known in the family and the daughter is negative, depending on how old that grandparent was, that would help us identify when to start her imaging. The rule of thumb is usually start imaging someone 10 years prior to the earliest breast cancer diagnosis in the family.
Yeah, or age 40, whichever one comes first.
Right.
Yeah. Part of the other reason why we tend to test in the adult years is so that they can consider some life choices like life insurance, long-term care, or disability. And I mention those specifically because we have federal laws that protect us against genetic discrimination. However, it doesn't cover those specifically. So we would, we prefer that someone consider getting certain insurances in place. That way they don't have to worry about coming back positive and then trying to get life insurance and being denied because they have a genetic mutation.
Great. So a question that we got through private message. If a genetic condition is found in me, what are the implications for my children, siblings, my parents, and other relatives?
Sure. If it's a mutation that is passed on in an autosomal dominant fashion, and what that means is that it doesn't matter if you're a male or female, if you have a mutation in that gene, then there's a 50-50 chance of passing it on to your children. And most likely it must have come from one of your parents. And if it is inherited from one of the parents, then the siblings also have a 50% chance of sharing that exact same mutation. And then if your siblings share it, then their children would be at risk as well. Every once in a while, there are some genes that have what we call de novo mutations. And what that means is that you're the only one in the family and that your siblings and your parents don't share it, but you could then pass it on to your children. And these new mutations happen randomly after conception, and we're not exactly sure what causes it, but that would be some of the implications for family members. And then if we find that they share that mutation as well, then we would start screening a lot earlier compared to the general population.
There's only just a few of these conditions that are what we call recessive, where instead of just having one gene mutation, you have to have two gene mutations, one from each parent, in order to have the high risk for cancer. having just one gene mutation for that gene is not sufficient to really increase the risks. But those are not the majority of them. Most of them are dominant, as you said. I think this is a good time to also dispel one misconception about genetic testing for things like BRCA1 and 2 is that guys don't need testing or that they can't pass these on. That's not true. They can certainly carry these, but because they don't have as much breast tissue, but they do have some, and because they don't have ovaries, their risks just look very different than the risk for women. But they do have some increased risks, like an increased risk for male breast cancer, for prostate cancer, and a couple other cancers like pancreatic or melanoma. So it is still important for guys to know about it. Furthermore, if a man does inherit something like this, he does still have that 50-50 chance of passing on to his children, including his daughters. So a lot of guys that I talk with are testing for themselves, but also for their daughters.
Mm-hmm. Are there any other common misconceptions about genetic testing? But before you answer, I just want to invite everyone that's tuned in to get in your last-minute questions. And if the experts can't get to them today and you're watching the recording, we'll try the best we can to get an answer for you. But are there any other common misconceptions that come to mind?
No, we had talked about a few of these. I think the being transmitted by guys is the big one. That not all the genetic tests are equal. We talked a little bit about 23andMe versus a clinical test. That is not a replacement for a clinical test. We talked a little bit about how being negative does not necessarily mean you get to ignore the family history. We still got to think about the family history. Or even a positive is not a guarantee someone would get a cancer. It just means those risks are a lot higher.
Right. It really depends on what comes back positive. We had mentioned Lynch syndrome several times, and there are actually 5 different genes that can cause Lynch syndrome. Some of them put you at a very, very high risk of colon cancer, up to 80%, and others in Lynch syndrome, it's closer to about 20%. And then if it's one of the more moderate risk genes where it does increase your risk, but not quite so high, sometimes it doesn't look like there's something in the family because we're not seeing as much cancer compared to some of the really, really high penetrant genes. And I guess that kind of reminds me of one other thing where most insurance companies do cover genetic testing if you meet certain criteria. But unfortunately, we're actually missing a big chunk of these families because they don't meet their specific criteria. And it could be that, maybe there's a mutation in the family and it's one of those lower penetrant genes. And so that's why they don't meet that case. But thankfully now there are some more affordable out-of-pocket options as well that can range anywhere between $100 and $250.
And also some people think, if I did my testing 10 years ago, I'm done, I'm negative, I don't need to see my genetic counselor again. Well, things change. A lot of these genes have been added to these panels even within the last 2 years. We're constantly learning about new genes that can go along with inherited cancer risk. So if, let's say, you had been referred to a genetic counselor previously because of a family history or personal history of cancer and had negative testing, if it's been a while, come back. We can certainly have a conversation about what's been learned since then and if genetic testing could be helpful for you. In fact, some families think, some individuals think to maybe even bank their DNA so that it might be available to family members in the future in case we do learn more and that person is passed.
Oh, thank you. Is there anything else either of you want to add for our audience today before we wrap it up?
I would say if you have questions, is genetic testing or counseling right for you? Talk with your doctor and have a conversation about your family history or personal history. They can usually put in a referral to a genetic counselor in your area. If you don't have a primary care and you would like to explore genetic testing with a counselor, we can put up our phone number for our scheduler's office.
Yeah, and we tend to travel in the Puget Sound region, so we're not just in Seattle. We also go to Ballard, well, that is in Seattle, but also Edmonds and Issaquah, and there are several other genetic counselors that are in the state.
Great. Well, thank you again for joining us today and lending us your expertise, and thanks to everyone that tuned in today.